Good evening, and I want to just echo Pat's sense of being honored to be able to come speak with all of you and to have the opportunity to visit Perth and Western Australia. This has been a place I've been longing to come to because of Alan and Vivian, who've been telling me about it for years. And I've had the opportunity to come to Australia a number of times in the past, but hadn't quite made it this far. And I have now gone. One of the reasons, besides the beauty and the opportunity to come visit this particular place, this now means that I have gone as far as I can go without actually starting to head back. So I'm going to, in some ways, I feel like I'm going from the sublime to the ridiculous. But I don't really mean it that way. I want to just talk about what's gone on in the United States, particularly around healthcare reform, as an example of the issue, in some ways, of dealing with meaning, and how people sort out what it is that they're trying to accomplish in a society. I also, I recognize we've been a little bit American focused. There's a certain critique of the United States that's underlying this, and maybe this is another way to talk about that. I had a good friend, Alan was a friend of his as well, by the name of George Witt, who was a psychiatrist from the Netherlands, who I met, actually, as I think I met you, Alan, I can't actually remember, going to the Institute for Psychiatric Services meetings in the United States, which are sort of the counterculture within psychiatry, and the place where folks like Pat would come and speak, and we'd be all going, yes, absolutely, you're completely correct. George would come with a whole troop of folks from the Netherlands, and he kept coming every year. I mean, he came for almost 30 years. Unfortunately, he died a couple years ago. The last conversation I had with him, and one of the inspirations for this talk, was that he called me up, and he called me the day that the Congress had passed the Affordable Care Act, and he said the first things out of his mouth on the phone were, "Welcome to the world of civilized nations," for having at least tried to get close to full accessibility in your health care. But George would come to the United States, and he came for many years to these meetings with two intents. The first intent was that he wanted to see what were the really good ideas that were coming up in the United States. So despite the sort of edge we've talked about before, it is probably fair to say that there are many, many good ideas that do come up in America, for lots of reasons. Of course, there are lots of reasons. None of them, as George would note quickly, ever go to scale. They all stay very small in little places. If they're a good idea, that's what happens to them. They just stay small. He said, on the other hand, he would come back to, he'd take those good ideas, he'd come back to the Netherlands, and he would bring them to scale in the Netherlands, make them happen. He said, on the other hand, you also have some really, really super bad ideas, terrifically horrible ideas. They seem to go to scale in America immediately. So I come back to the Netherlands, and I put a little more dirt on the dike to try to keep away the flood of American ideas. So I'm going to present what's going on in the United States in hopes that you might hear some good idea that you could bring to scale. And I don't know necessarily if you have a way to mount up a dike, but maybe you can figure out a way to keep the Great Barrier Reef as much of a barrier as you can from some of the really super bad ideas. So what's gone on with psychiatry and healthcare reform? Let me just talk a moment about the circumstances in the United States. So in the United States right now, as you may be aware, we have we are now spending about double the amount of any nation in the world on our healthcare system. So take whatever money you're spending, double it, and then you would have an idea about how much money we have in the States being spent on healthcare. It's growing very quickly. It has, in the last couple of years, it's moderated a little bit, so I don't want to overstate this point, but we're somewhere close to around 18% of our gross domestic product is healthcare. Now, that might be a really good thing if we were super healthy, right? If we actually were a society of extraordinary health. But the truth of the matter is that everybody, any study that's ever looked at this has found that we have, at best, middling health, and in some areas we have just atrocious healthcare and health outcomes. And if anybody does any kind of look at the quality of the healthcare we're delivering, it's at best spotty and often just generally pretty poor. And then the main thing, and the reason that George called me up on that morning, that has been a real concern, is that we'd had close to 50 million people in the United States who had no health insurance of any kind. So they were dependent on some form of charity care or et cetera, or no care at all. So have folks heard of Don Berwick? Is this a name that you guys are hearing around at all? If you haven't heard of Don Berwick, this would be a person who's got good ideas who you will be hearing about. He was actually he's a pediatrician. He was made the head of the Center for Medicaid and Medicare, which is the largest, that's the federal agency that funds our public sector funding. It's an agency that is about $1 trillion a year. So you can imagine the size of this entity. But because of his particular attitudes towards health and healthcare, the Congress, as it's currently constituted, would not recognize him as the leader. So he was appointed by Obama while the Congress was in recess, and when Congress finally got its act together, they pushed him out. So that's an example of a good idea that couldn't really come to scale. He has pushed something called the triple aim, and this would be the talk you would hear out of Americans now about what it is we're trying to achieve in our healthcare system. That is high quality, excellent health outcomes, and less cost. And then the political side underneath that is the whole idea that we would be making it more accessible to people. Right, so these are the four things that have really been pressing on American healthcare in the last couple of years. I haven't mentioned psychiatry, and there's a reason for that, and I'll come to that in a second. And that is the notion of parity. So in the United States for a long time, and I don't know how it's set up in Australia, in the United States, if you were receiving a mental health service, whoever was providing that mental health service could be paid at a rate that was far less than would be paid for a similar other medical service. So there was many years of activity trying to get mental health services to be paid for at the same rate or in the same general ballpark as you would pay for general health services. And that was particularly insurance companies would not pay. And to some degree, even the federal government would not pay at rates that were equivalent between psychiatric and other medical services. So you're probably familiar with Senator Kennedy, Ted Kennedy. This was his major push. Right, and his son, Patrick Kennedy, who was a congressman and has now become a major mental health advocate, this is still his major push. We passed legislation in 2009 to create parity, but now there is the issue of how do you actually enforce that? What is that actually going to look like, and who's going to police that? So that issue has been passed by Congress, and because of that, the assumption was by Congress that mental health now is taken care of. And we're now talking about all of healthcare when we talk about healthcare reform, mental health having been brought into the general package by the Parity Act. So the critical issues for the Affordable Care Act for the United States were obviously addressing this issue of uninsured people or underinsured people. And this has been a highly contentious, very controversial issue because while there were a number of ways that the Affordable Care Act, and I don't want to go into this in too much detail unless somebody wants to talk to me about it later, there were a number of ways that the Affordable Care Act increased access to health care insurance. One of them was to expand the eligibility for a program called Medicaid, which was the program out of the United States government, out of the federal government and state governments that takes care of poor people. They expanded the eligibility from 100% of poverty and below to 138% of poverty and below. So that a massive expansion of the number of people eligible for Medicaid. Unfortunately, our Supreme Court decided that that could not be enforced on could not be enforced on states, so states did not have to take that. And a number of states, generally Republican states with Tea Party leanings, turned this money away. And it is it's a major, major tragedy and an incredibly stupid act, in my humble opinion. I'm in a state where my governor has turned this money away. But at any rate, the notion of access to care was really the big deal for the passage of the Affordable Care Act. Underneath it was a couple of things that I think are really important to be aware of, though, that are more important for psychiatry over the long haul. And that is that there's a fundamental notion that's going on in the United States. It's not talked about a lot in any kind of explicit way, but I think it's at least worthwhile sort of trying to describe a piece of it. And that is that we are in a significant process of trying to redesign how our healthcare system works in the following way. We have a system which is extremely weak in terms of primary care. You know, there's just a very limited concept about what primary care would be. There is no sense that people necessarily tie into the healthcare system through a primary care provider. There is a very heavy emphasis on specialty care, which would include behavioral health care, psychiatry. And I can tell you that the evidence is very clear that a system that is built on specialty care in the way that we are is extraordinarily expensive and has bad outcomes. Just doesn't work. So we are aware in the United States that other systems around the world where there is a greater focus on primary care and a sort of rebalance on the specialty care have been more effective as healthcare providers in addressing healthcare. Now, the dilemma with this is of course, that one of the concomitants of the reason that we have such a focus on specialty care and don't have a focus on primary care is because we don't actually believe, and haven't believed until recently, and maybe still don't, that people should have access to health care, right? It's not clear. And on top of that, there's our just general underfunding of a social welfare state of any kind. So we don't know necessarily if it's primary care per se that produces better health or having a better social welfare state that does it, or is it a combination of better primary care and social welfare state that produces this. But right now, at the moment, we're not prepared as a society to move to a better welfare state. I hope that changes, but that'll be a whole other conversation. We are starting to move towards having a better primary care capacity. And I think that's really important for psychiatry, because if we redesign care around primary care, then where does psychiatry and specialty services, or psychiatry and behavioral health, fit into that? There are three components to this. I don't know if any of these terms are familiar to you. One of them is the medical or health home. That's essentially a description of what a primary care capacity would be for each individual in our society, so that everybody has access to a point in the healthcare system where there are healthcare providers who are organized at a primary care level to address whatever kind of medical or health-related issues they have, including things like health promotion, and activities that would be not so much about curative or taking care of already existing illness as much as anticipating and avoiding potential illnesses. Part of the issue that's going on right now, and is a huge issue in the States, is how does psychiatry and behavioral health fit into this medical home? So we are now really thinking very hard about inventing, because there were some efforts earlier on, many years ago, to figure out where psychiatry and primary care actually fit together. So that it's not so much psychiatry as a specialty service, but psychiatry as part of the primary care home. That's a real conversation right now, and a contentious one, because there is a very significant specialty care emphasis in psychiatry that does not want to give up the power that it has by being part of primary care. The next term is this notion of a medical or health neighborhood. That's actually how specialty care is organized around the primary care home. And I think there's a lot of room. We really have never thought about how a medical home or health home would have a specific relationship with a whole range of specialty care capabilities and capacities. It's just never been put together, particularly in the mental health world. And then the thing that holds this whole process together is something that we would call an accountable care organization. I don't know necessarily if there's an equivalent to this idea in Australia. You know, what I've seen of for example, the Western Australia Mental Health Commission is that it's charged with the mental health issues, but I haven't figured out who's charged with the overall health of the population, who's going to be held accountable for making sure all this stuff fits together. And maybe you all know what that answer is, and tell me after my talk. So the key elements for psychiatry and all this are how are we going to integrate with primary care? Or another way to say this is, how does primary care psychiatry become part of primary care medicine? How do we put those pieces together? Another element that is, which I haven't emphasized yet, but I think is important to emphasize, is that within medicine across the board, there is a growing appreciation that if people have illnesses that don't go away when you treat them immediately, like if acute care doesn't work and they're going to have an ongoing medical problem of some kind, it's very likely that they're going to have to work really hard to take care of themselves. And we're in a position of helping them in that process, but we are not going to solve their problem. They're going to have to be participants in it. So it's become really clear that people with ongoing medical concerns or people who are trying to protect their health are going to have to be actively engaged in their health and their health care. That is the language that medicine speaks. In psychiatry, that is what we talk about when we talk about recovery. That's an engaged person in their own health. And then thirdly, another issue for psychiatry, which we were a little bit better than the rest of medicine in this, at least in the States, and I think we're starting to infuse some of our awareness into the rest of medicine, is how critical the social and ecological environment that people live in is to their health. And what are the things that we can do both for individuals and groups of populations or populations as a whole to improve the circumstances in which they are living so that it's possible for them to be healthier. We do a lot of work around care management, navigation through human services and other kinds of things. We obviously have to get a lot better at this in psychiatry, but we are better at it than the rest of medicine, and we are now being asked to sort of help that process develop. So that the notion of health protection and health promotion is something that psychiatry has some possibility of leading in. Of course, from the conversation that Pat was talking about, if we think about this all as purely neurobiological and pharmacological, none of these things that I've talked about will actually be of any particular use. So I think we're coming to a head in this particular crisis. Problems that we face, and then I'll end with this, is that we don't have a workforce that's in any way ready for any of the stuff I've just talked about. 50% of the psychiatrists in the United States are over the age of 55. So we're facing a major workforce problem. As you heard from Alan Francis, and I was trying to think of this, other than a few medications which are really not, maybe slightly more convenient than the medicines that I've used in the past, there have been essentially no biological advances that I use in my practice. I don't know about anybody else here in the last 30 years. There continues to be a real wariness in the field, in psychiatry in particular, in the profession, to this whole notion of recovery that I think we're starting to see evaporate a little bit, but it is it's still a significant problem, and because of it, an issue in the United States is that that psychiatrists and psychiatry and mental health providers in general don't have a whole lot of support from a patient base who are sitting there saying, yes, fund these guys, they need to do better work, and we would like to see more resources going to them, because frankly, the outcomes that we're having are just not all that good. So those are the dilemmas we're facing to actually move this all forward, and I will stop there.